Hello again. We're going to talk here about some perioperative complications. And I want to just go over some definitions first because some of these can be a little bit hazy. The term perioperative refers to the time proximately before, during, and after the surgery. So maybe a few hours before the time during the surgery and then a few days after the surgery. It's not very strictly defined. It's a loosely defined word, but used in the context of disease, it generally refers to a process that occurs shortly following a surgery. The term intraoperative, on the other hand, is a very specific term, and it strictly refers to the time that the patient spends in the OR. So from the beginning to the end of the surgery, when the patient's on the operating table. And you probably know that preoperative refers to before the surgery starts, and postoperative refers to after the surgery finishes. So we're going to talk about some of the things that go on intraoperatively that may or may not contribute to some of these problems. We're going to just briefly run past malignant hyperthermia. I cover it in the Wonder in Drugs lecture. We'll talk about tension pneumothorax, perioperative MI, and then postoperative urinary retention, sort of under the general category of low urinary output. And then I'll just go through some other remarks. And also just to note that this is an overview of complications that happen during most surgeries or sort of general surgical complications. This is not a total review of all the possible complications that could happen during surgery. Of course, if you're getting neurosurgery, there are complications that are very distinct to that versus if you're getting bariatric surgery versus if you're having orthopedic surgery. So I tend to try to talk about those with those topics, but these are complications that can pretty much happen during any surgery. Okay, so what's going on intraoperatively? What happens? Well, first off, the patient receives anesthesia. That happens pretty much in every surgery. Usually it's general anesthesia. And general anesthesia, besides reducing pain and making us forget about the surgery, it has two other effects, and that is to mildly reduce blood pressure, which is usually not a problem, and also to reduce the body temperature. Those are just side effects. Now, we address the body temperature issue by keeping the OR very warm. If you've ever scrubbed in for a surgery, you probably know this. It's kept around 80 degrees. It's really warm in there. And then we also use these sterile heated bags, which I'll show you a picture of what one of those looks like, or just sterile blankets, warm blankets. Then certain anesthetics can also precipitate malignant hyperthermia. So on the other hand, you could get hyperthermia out of anesthetics. And these anesthetics particularly are succinylcholine, halothane, and any anesthetic that ends with flurane, fluorane. So sevoflurane, isoflurane, etc. So malignant hyperthermia is a possible complication, but usually the effect of anesthesia is hypothermia and hypotension, just mildly reduced blood pressure. So we're usually not concerned about the mildly reduced blood pressure, but we do have to address the reduced body temperature, and we do that just by these keeping the ambient temperature of the room warm and using heated blankets. Another thing is that the patient is intubated, so that carries with it some risks of its own. Risk of a misplaced tube. You can have tracheobronchial injury. You can also get aspiration and asphyxiation. So the aspiration is usually addressed prophylactically. When we have planned surgeries, we tell the patient that they can't eat 24 hours before the surgery so that their digestive system is pretty much totally empty before the surgery, so they can't puke anything up and aspirate it. As I mentioned, there's always a certain degree of hypotension. This is usually mild and there's no problem with it, but in some patients, just because of their health and their predispositions, it can precipitate problems, notably myocardial infarction. There's always going to be some blood loss during surgery. Certain surgeries are worse than others. If you're doing a cyst removal, you're probably not going to have a whole lot of blood removal versus blood loss as opposed to if you're doing a C-section where you're going to have a lot of blood loss. So this always happens to a certain degree, but nevertheless, blood for transfusion should always be kept on hand just in case of an emergency. And then finally, the body is stressed, and that's just because of the incision that you're making and all the manipulation that's happening. So all patients who are on long-term corticosteroids, and you absolutely need to know this for the USMLE and for real life, all patients that are on long-term corticosteroids or have any kind of adrenal insufficiency, so patients with Addison's disease or patients with autoimmune disorders where they're taking steroids every day, need to get extra higher corticosteroid dosages before the surgery. Okay, because remember, these are patients who their adrenals, or more accurately, their pituitary is shut down for ACTH formation, and so they're totally reliant on the corticosteroids that they get in their dosages, in their medication. And in a normal person, when you do surgery, your ACTH levels will jump up, and so your cortisol levels will jump up. But these patients, they wouldn't have that because they don't produce ACTH. They're dependent on their corticosteroids that they get in their medication. And so they need to get that extra boost to put them at par with their corticosteroids. Okay, hopefully that makes sense. So all patients who are getting surgery, who are on long-term corticosteroids, need to get an extra dose before the surgery. Okay, so this is the Bair Hugger from 3M, and this is a good example of that heated sort of bag or blanket that you can put on the patient to keep them warm. And it just has a little opening where you're going to do the surgery, so this patient is probably getting abdominal surgery. All right, malignant hyperthermia. For the gist of this, see the Wonder and Drugs talk. Just remember, big thing with malignant hyperthermia is that it happens with anesthetics, and these are patients who will have a progressively climbing fever and rigidity. And the treatment is immediate administration of dantrolene. But for more information, you can go back and look at that lecture. Okay, tension pneumothorax. This is a collapse of the lung due to a puncture of the pleural space. And the pleural space has a negative pressure, and so when it's punctured, what's going to happen? Positive pressure from the ambient air, because pleural space is a negative pressure, so the pressure from the ambient atmosphere is going to rush into that negative space. And so when it rushes in to the pleura, it's going to compress and collapse the lung. So atmospheric pressure rushes in and collapses the lung, and subsequently air is going to continue collecting in the pleural space and compress the mediastinum. And that compression of the mediastinum is why we call this a tension pneumothorax. So with a compression of the mediastinum, this is why this is a big emergency. When you compress the mediastinum, you're compressing the heart, because the heart is part of the mediastinum. And as you compress the mediastinum with that increased pressure of air in the pleural space, you're going to reduce the heart's pumping ability. Now, patients who are in surgery can be at risk for tension pneumothorax for two reasons, possibly more, but these are the two big reasons. One, that they're getting positive pressure ventilation, so you're pushing positive pressure into their lungs, you put them at risk for injury. So our lungs become weaker with age and with certain diseases. Those diseases are things like interstitial lung disease, COPD, cystic fibrosis, and TB and other lung diseases. And so those patients are at increased risk for tension pneumothorax. So when you're giving them positive pressure ventilation, you're putting a stress on the lungs, and so patients with already diseased lungs are at risk for having that puncture into the pleural space. And then 2, any kind of antecedent injury, so if they have rib injuries, namely, or the surgery type. If you're operating on the thorax, obviously there's an increased risk for tension pneumothorax than if you're operating on their ankle. So what's the history in these patients who have tension pneumothorax? Typically, they're patients with rib fractures or possibly lung diseases, but this can happen to anybody. You don't have to have these predisposing factors. What are the symptoms of tension pneumothorax? Okay, on the USMLE, in real life, in questions you probably worked on in the past, you've probably seen tension pneumothorax in the context of an awake patient who can tell you, my chest hurts, I'm anxious, I can't breathe. This isn't going to happen with a surgical patient because they're usually going to be sleeping. So in an awake patient, yes, there will be anxiety, chest pain, respiratory distress. However, in a surgical patient, your signs are going to be on your monitor. And they're going to be a falling blood pressure because we're compressing the mediastinum, we're compressing the heart, and we're reducing the heart's pumping ability. And then we're also going to have an increased central venous pressure. And again, that's just because of the backup. Because the heart can't pump, all the blood that's flowing to the heart is going to get backed up. And that's going to increase the pressure in the veins. And so even if you're not monitoring your central venous pressure, what you can look for is distended jugular veins. Other things, even though you're supplying oxygen to this patient via chest or via tube, you're going to have no elevation of the affected hemithorax because that lung is collapsed. And if you auscultate, you won't hear any sounds on that affected side. The diagnosis, when generally for tension pneumothorax, is clinical. Always during surgery, it's going to be clinical for the most part, in addition to your signs on the monitor. And the treatment is an emergent needle decompression, and that's the same for any tension pneumothorax. And you're going to be doing this at the second intercostal space at the mid-clavicular line. So emergent needle decompression or thoracostomy is the treatment for all tension pneumothoraxes, and after that it's going to be the surgeon's call on whether to continue or abort the surgery. Usually they're going to abort the surgery, mostly because when you do an emergency needle thoracostomy decompression, you have to break your aseptic technique, and so you're usually going to have to abort the surgery. But either way, that you're not going to be asked that in USMLE. You will be asked what the treatment is, and it's emergent needle decompression, particularly done at the second intercostal space at the mid-clavicular line. And then after that, once the patient is wheeled out, they should have a chest tube placed, a formal chest tube, post-operatively, as with anybody. Okay, so how do you perform a needle thoracostomy? This is good to know even for outside of surgical contexts. So first off, you're going to locate the clavicle on the affected side, and the clavicle, of course, is that top bone. And you want to identify the mid-clavicular point, the middle point of the clavicle. And if you draw a line upwards and downwards through that point, that is your mid-clavicular line. So you should be able to identify your mid-clavicular line. Sadly, a lot of clinicians are not able to identify the mid-clavicular line. All you have to do is palpate where the clavicle hits the sternum and where the clavicle hits the scapula. And right in that midpoint is the mid-clavicular point. And then going upwards and downwards from there would be your mid-clavicular line. So here's your mid-clavicular point, and then up and down from there would be your mid-clavicular line. Okay, once you've located the clavicle and the mid-clavicular point and line, you're going to palpate slightly downwards to identify the second rib. Now remember that the first rib is behind the scapula, and you won't be able to feel the first rib. So the first rib that you feel once you start going down from the clavicle is your second rib. Right underneath there is the second intercostal space below the second rib. So the second intercostal space. And this is just that muscular, non-bony part of the rib. And this is the second intercostal space. Right in the middle, on the midclavicular line, In that the second intercostal space would be your second intercostal space mid-clavicular line. So it's the second intercostal space because it's right below the second rib, and the intercostal, or the mid-clavicular line, rather, right here. And this is going to be where you're going to insert your needle. Now, if you're unsure as to whether you're on the mid-clavicular line for one reason or another, it's best to err on the side of lateral. Because the one thing we're really worried about as far as sticking a needle into somebody, into their chest, is sticking a needle into their mediastinum. And that can result in big problems. So if you're unsure, err on the lateral side, but you should be able to identify your mid-clavicular line. Okay, the perioperative myocardial infarction. Now, this is just like any other myocardial infarction. It just happens during or shortly after surgery. But there's a few unique things about this that are worth knowing. So, patients in and shortly after surgery are at increased risk of myocardial infarction because of hypotension. Anytime you administer anesthetics to a patient, they're going to have a degree of hypotension. And when the blood pressure drops, the perfusion pressure drops most of the time, unless you have vasoconstriction. So with the perfusion pressure dropping, that can result in myocardial hypoxia and ischemia. And if you already have hypoxia, you can tip the balance to the point where you're getting ischemia, where the cells of the myocardium are no longer able to function and they become ischemic, and now you have a myocardial infarction. So patients who already have maybe unstable angina, or a history of unstable angina rather, or angina as a history, they're at particular risk for this. So typically the patients who get this are patients with a history of heart-related issues, prior MIs, cardiac artery disease, and so forth. A precipitous perioperative hypotension also strengthens the likelihood. So if they get anesthesia and their blood pressure makes a big drop, then that's going to increase the likelihood because they're going to have a big drop in their perfusion pressure, because that perfusion pressure is related to your blood pressure. So what are the symptoms? Again, it's going to be different than typical myocardial infarctions, just simply due to the fact that this patient's not awake. So you can't rely on them telling you where it hurts, how it hurts. So if the patient's on the table, there's really not going to be many symptoms other than if the heart loses its pumping ability, which it may or may not. Usually the diagnosis will be suspected based on the fact that the patient is already on an EKG, and that's useful. So the anesthesiologist, if they're looking at the EKG and monitoring it, or the nurse who's looking at the EKG, they can tell you, hey, there's ST elevation or ST depression, you might want to check this out. So usually the diagnosis will be suspected on the basis of your EKG. In severe circumstances, the heart may lose its pumping ability, in which case you would have a dramatic hypotension and cardiac arrest. Now, if the patient is post-operative, they're pretty much going to just be like any other myocardial infarction patient. In that case, your first diagnostic step would be to get an EKG. But one of the nice things about patients who are on the table is they're already on an EKG. Okay, diagnosis. So, clinical, if the patient is on the table, and I guess I shouldn't say clinical, you're looking at the EKG, but you already have the patient on the EKG, so you don't need to do any more steps. Labs are going to be useful for confirmation. So you should get cardiac enzymes. Troponin is the most reliable for an acute MI because it increases early. If the patient is post-operative, you just pretty much treat it like any other MI patient. So you want to give them aspirin. That's the best initial therapy, unless it's contraindicated for one reason or another. The best initial diagnostic step, of course, is EKG, in which you'll be able to diagnose whether this is STEMI or non-STEMI, or if it's a myocardial infarction at all. You'll also want to get enzymes and so forth. An important pearl of knowledge: you cannot give thrombolytics to patients who are perioperative. And the reason for that is we need them to stop bleeding. So no thrombolytics for patients who are perioperative. I don't know what the exact cutoff time after surgery is where you can give them thrombolytics. Now that I think about it, I'm sure there's somebody. I'm sure the American College of Surgeons have established some sort of date, post-operative date, as to when you can give them thrombolytics when it's safe. But in the immediate, in the perioperative period, 2, 3, 4 days after their surgery, no thrombolytics. Remember that normally we treat patients who have STEMI with thrombolytics, but not post-operative patients, not perioperative patients. I'll look up and see what that specific date is that's recommended when you can give them thrombolytics. If any of you know, definitely comment. Okay, mortality is higher with MIs associated with surgery, and that's probably because more perioperative MIs have they're silent. So if you have an MI in the perioperative period, they're more likely to be silent, and so they go undetected until the patient goes into cardiac arrest. So it may be wise, because of this, that to place higher risk patients who have an established history of unstable angina or with prior MIs, to place them post-operatively for the first few days on telemetry, because if they have a silent MI with telemetry, then you can get that. Okay, so urinary complications, very, 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 very common. The symptoms for urinary complications would be either the patient isn't voiding, there isn't any urine coming out, or that they want to void but they can't. And those both have to do with different urinary complications. So an adult patient should urinate approximately 1 milligram per kilogram per day. So that's going to be different based on the size of the person, but that's the rule. The potential causes, as far as urinary complications, are post-operative urinary retention, or POUR, POUR. Post-operative urinary retention is extremely common, especially in patients who have received general anesthesia, which is most of the patients we're talking about here in surgery. So this is one to really, really remember. And in these patients, they have a normal urinary output, but they can't get the urine out. So it looks like they have a low urine volume. Obstruction would be no output at all. This would be either because there's an obstruction distal to the bladder or proximal to the bladder, but an obstruction would be no output. Dehydration and pre-renal failure both would be a low output of urine, but not no urine. So even with pre-renal failure or dehydration, you should still have some output of urine. It's only obstruction where you would have none. So urinary retention, post-operative urinary retention is extremely common. Up to 70% of patients have this. I had my own experience with this when I had my appendectomy. And if it's actually, most surgeons actually expect this. So there are some surgeons now who, I'm not sure if this is recommended, but I've seen a lot of surgeons who just place a Foley catheter into their patient prior to the surgery and leave it in for a day, and that's to prevent post-operative urinary retention, which, while it's not necessarily harmful to the patient if it's addressed, it's really a big pain in the butt for the patient because it's painful. So some patients will just put the Foley catheter in and leave it there for a while to prevent this, especially in surgeries involving the abdomen and pelvis. Most of the time, post-operative urinary retention is a residual side effect of the anesthesia. Remember what anesthesia does, it blocks the muscle, so at the neuromuscular junction. So this being a side effect, you should almost expect this. And this affects the detrusor and urinary muscles. So how do we differentiate whether this is poor or low urinary output? Okay, if there's no urine at all, then it's probably an obstruction. And the possible causes of obstruction, if they have a Foley catheter in, could be an obstructed Foley catheter. So you can actually get a kink in your catheter, or the catheter may be placed incorrectly. That's one possibility. That should be the first thing that you check. Another thing, in an older man, you could think possibly BPH. Then there are other mechanical obstructions. So no urine at all, you should think obstruction. If the urine is present but in low amounts, then you should be analyzing the urine. So the possibilities when there's oliguria, low urine, you should consider dehydration or acute renal failure. So if it's dehydration, there's going to be a low urinary sodium. And why is there a low urinary sodium in dehydration? Because your kidneys are reabsorbing the sodium to maintain your sodium concentration in your blood. So a low urinary sodium suggests dehydration. If it's a high urinary sodium, meaning above 40, then this reflects a disordered sodium reabsorption. If you have a patient who's got a low urinary output, it means they're not getting fluid. That's likely the problem. If they have high sodium in their urine, that wouldn't make any sense. We would expect a patient who isn't getting fluid to have a low urinary sodium in that fluid, in that urine. So a high urinary sodium reflects a disordered sodium reabsorption, and hence the problem is acute renal failure. So if this is confusing, you can go back to the nephrology sections. I talked about acute renal failure versus dehydration there. But just remember, you can differentiate dehydration versus acute renal failure based on your urinary sodium. We expect, when we have a low urine amount, we would expect a low urine sodium. But if it's a high urine sodium, then indeed it is acute renal failure. Okay, now if the urine is present in normal or high amounts, then all but certainly this is going to be postoperative urinary retention. And so how do we manage this? If the patient is complaining of an inability to void, the best initial step is bladder sonography. And so now here we're talking about postoperative urinary retention. So you have a patient who wants to void but can't. With patients who have low urinary output, they don't want to void because their urine is practically, their bladder is practically empty. So patients who want to void but can't, you can pretty much guarantee that they have postoperative urinary retention. So your first step is going to be a bladder sonography, because you want to see how much urine is in there. That's going to affect what you do. So with the bladder sonogram, what it is, it's not like a sonogram which you would do for like a pregnant woman. It doesn't give you a picture, it gives you a number. And you hold it over the bladder, over the suprapubic area, and it gives you a number. And that number is the number of milliliters that the patient has in their bladder. If it's 600 or more, then you're going to do a straight catheterization, which is just a one-time catheter. And again, that large volume of urine strongly suggests postoperative urinary retention. They're not dehydrated because they've got urine, and they're not having pre-renal failure because, again, they have a high amount of urine. So this just continues to reaffirm your initial diagnosis. The bladder can safely hold 500 to 1,000 milliliters, but it can even go higher than that, but then you're kind of pushing it. If the volume is low, so if you do your sonogram and the volume is low, then you should, when you can get urine out, you should get a urinalysis. And what you're looking for, as mentioned, is the urinary sodium concentration, or the fractional excretion of sodium, which will help you distinguish between dehydration and pre-renal failure. Now, with the fractional excretion of sodium, if it's low, if it's less than 1, then the problem is dehydration because you have low concentration of sodium. If it's high, then the likelihood is pre-renal failure. Now, if you're catheterizing the patient who has post-operative renal failure, you should check in every 6 hours, and if they still can't void, then you should again catheterize them. And if they need to be catheterized a second time, you can do a straight catheter, but then if they need it a third time, you should insert a Foley catheter. An alternative method for diagnosis, and I don't imagine that the USMLE would want you to do this for diagnosis, however they may illustrate it on a vignette. If they have a low urinary output, what you can do is just give them a bolus of normal saline, give them fluid. And what you look for is the urinary volume. If they're dehydrated, well then the urinary volume is going to come up. You've cured the problem by giving them fluids. If the urinary volume doesn't come up, then the problem is likely pre-renal failure. I have my own story with urinary retention, post-operative urinary retention. I had an appendectomy about 3 years ago, and I was all of a sudden in major pain, and there was a nursing student, and so of course they had to trot her in to show her how to use the sonogram. And I'm like, I already know what it is, just cath me, dang it. And mine read 999. And so then they cathed me, and of course I had to get my catheter put in by the nursing student, and it was not fun. Wound up being 1.6 liters, I swear. That's the most I've ever seen in anybody. Alright, so some other things that you can see post-operatively, perhaps not as pertinent, but still important to know about. Shoulder pain following a laparoscopic surgery is very likely common, and it's because of diaphragmatic irritation. So what's happening here is that when you do the laparoscopic surgery, you're inflating the abdomen, and so that puts irritation on the diaphragm, and it stimulates the phrenic nerve, irritates the phrenic nerve, and the pain from there refers to the shoulder. Confusion is commonly seen in older patients following surgical procedures. If you see confusion in a post-operative patient, the first thing you should think of is hypoxia. So look at your SATs, get ABGs if necessary. You should control your patient's pain, but preferably not to the point where it sedates them. So if possible, they should be using their incentive spirometer as much as possible. And that is to ward off atelectasis, which can result in pneumonia. And then remember that fever, especially as an isolated symptom within the first 24 hours, is usually normal, but don't ignore it. Always do a workup, do a physical, check the nursing notes, check the operative notes. It's always important to pay attention to fever, even if it's within the first 24 hours. If you don't find anything, it's certainly realistic that this is just a normal fever, and it will go away within the first day, post-operatively. And that's it.